Good evening, everyone. I'm just going to wait for everyone to join us. Okay, so whilst everyone's joining, I'll just start the introduction now. So good evening, everyone. Thank you so much for joining us tonight for our latest medical science lecture titled, Are Biologic Drugs to Treat Rheumatoid Arthritis Harmful in Pregnancy? My name is Nora, and I'm a current fifth-year medical student here at UCL and your chair for today's event. In today's fascinating lecture, Professor Ian Giles will discuss whether biologic drugs in pregnancy have harmful effects on disease activity and pregnancy outcomes. We want to keep these lectures as interactive as possible, so please use the question and answer function on Zoom to submit your questions for our speaker, Professor Ian Giles. We also have a Twitter hashtag for this event, and that's hashtag FMS Lectures. So Faculty of Medical Sciences, FMS Lectures. So just to repeat that, the Twitter hashtag is hashtag FMS Lectures. This lecture will be recorded, and a link to the recording will be sent out via email to all the attendees after the event. Before I introduce our speaker, we would like to know about our audience. So this is the first part of the interactive aspect of our lecture today. So we have run a poll. If you could just vote on the poll that you should see now on your screen, and just vote to what group you belong to. So whether you're a prospective student, whether you're an undergraduate student, a PhD student, any academics in here today, any patients, or any other, just vote if you can. And then we will see the poll shortly. I'll just wait for the poll to be done. Perfect. Thank you so much for everyone that voted. So as we can see, we have a lot of prospective students here today. So that's really exciting news. I hope that you enjoy UCL if you end up joining. Some undergraduate students as well, some academics, some PhD. So a very good variety of attendees today. I thank you very much for those that voted. So now I'm delighted to introduce our speaker. We have Ian Giles, which is an honorary consultant rheumatologist at University College London Hospital. His specialist clinical and research interests focus upon the diagnosis and long-term management of patients with autoimmune rheumatic diseases. So thank you so much, Professor Giles, for joining us today. Over to you.
Thank you very much, Nora, for that introduction, and to UCL for this opportunity to speak on this topic. I've posed a question as my title, and hopefully you'll see why the answer that I'll provide you, which I'll give a spoiler now, is to say that yes, I think these drugs are safe, but there is a caveat. So it's yes, but, and I'll explain why. So firstly, it's traditional to give some disclosures in an academic lecture, although I appreciate I'm speaking to a much broader audience. So I mention some links with pharmaceutical companies. I'm helping to develop a drug to help treat another disease. And I will be mentioning some guidelines produced by the British Society of Rheumatology that I am also a member of the group that oversees them, but I did recuse myself from the process that was overseeing and approving my own guideline, you'll be pleased to hear. And I'd also like to mention some words that people might find upsetting. So I will be mentioning names of specific adverse pregnancy outcomes like miscarriage and stillbirth. I will also be using the words woman and women, although I do acknowledge that not everyone identifies with the gender that they're assigned to at birth. So who am I? I'm a rheumatologist. That basically means I'm a doctor who sees patients with arthritis that can be triggered in various different ways at University College London Hospital. And I'm a researcher working at the university, so University College London, and trying to understand how autoimmune conditions trigger disease and rheumatic illness, particularly in relation to pregnancy. So those two interests align in my attempts to try and understand and improve the management of rheumatic disease in pregnancy. So the aims of this lecture is to tell you a little bit more about rheumatoid arthritis in general, how it affects people, how that impacts upon managing that condition in pregnancy, and where biologic drugs come in. So this is a very nice schematic from the National Rheumatoid Arthritis Society, a large charity giving a lot of great information around rheumatoid arthritis that shows around the number of patients who are estimated to have this condition in the UK. It shows the strong female predominance for this condition, with 3 times as many women as men being affected. And it highlights how it's a condition with an overactivation of the immune system that causes that to turn against self and lead to damage to joints. But it can also cause more widespread inflammatory symptoms and affect other organs. And it's important to highlight that it does have can affect people of reproductive age that I've defined in that age category on this slide. So how many people with rheumatoid arthritis actually get pregnant? Well, the simple answer is we don't know. I've given an incidence from a global prevalence study of rheumatoid arthritis in the top part of this slide, and 0.24% was the figure that came out from that large study. So when I've tried to take UK prevalence studies, most closely aligned to women of reproductive age, I've come out with a figure of 29,000 women with rheumatoid arthritis in the UK who may plan or become pregnant. So that's an appreciable number of patients with that condition for whom this matters a lot, how to manage their condition during pregnancy. So what causes rheumatoid arthritis is important to consider first, and this very nice schematic shows that there's a number of factors that feed in: risk and susceptibility factors, things we're exposed to in the environment, act upon genetic makeup to cause an activation of cells in the body that triggers immune cells. T cells are important within that then lead to a production of various inflammatory factors from different cells in the body. And these are important targets for biologic drugs that I'll be telling you a little bit more about later on in the pregnancy. And if those factors are not suppressed, this very nice schematic from Versus Arthritis, which is the largest medical charity funding research for arthritis conditions in the UK, shows here. The normal anatomy of the joint is shown on the left. Untreated inflammation in the joint causes damage to the bone, damage to the cartilage, down to the damage to the surrounding ligaments and soft structures. And if it's not treated in time, that damage becomes irreversible. So how do we treat this condition? Well, painkillers and in particular non-steroidal anti-inflammatory drugs help to alleviate symptoms, but they do not reverse the disease process. That's where disease-modifying anti-rheumatic drugs come in, known as DMARDs for short. And these can be classified as conventional, non-biologic drugs or biologic drugs. Physical and occupational therapy are important adjuncts, and surgery is sometimes required to help restore function to damaged joints. So when we're treating patients, it's important to know how we measure response to treatment, and 2 of the main categories are shown here. We use something called the DAS28, which is the disease activity score that measures joint tenderness and swelling in the 28 joints shown on this schematic. Quite simply, squeeze the joint. Is it tender? Yes, no. Is it swollen? That's the assessor's subjective assessment. It's then coupled with a blood result of inflammation and coupled with a score that the patient gives. The higher the number, the worse they feel. That goes into an equation that comes out with a single number that can be categorized as no, low, moderate, or high disease activity. The gold standard of measurement of disease activity, however, that requires the use of an ultrasound machine and training in how to use it, so is not widespread in clinics up and down the land because not everyone can use these machines, shows how the ultrasound is used to identify inflammation in a joint. Imagine those are the small joints of a finger, basically no inflammation, black and white images only. With increasing inflammation, you get increasing red blobs, indicating new blood vessel formation and inflammation within the joint. And the goal of treatment is to put the patient into a ideally low/no disease activity state called remission. And that's defined by the DAS28 below a certain number, or no indication of inflammation on the ultrasound scan. So how do we achieve that? Well, this is a schematic from a recent consensus article produced by the European Alliance of Associations for Rheumatology that basically shows a pathway. And all you need to take from this is that there are 3 phases. The first phase which the patient may never leave if they respond to treatments within this section, do not involve biologic drugs. It uses the conventional drugs, and that may be all that people require. Not everyone, however, is stabilized or controlled in that way, and they have to progress to treatment with biologic therapies or sometimes small molecule inhibitors. And they are not biologic drugs. That's not what I'm talking about today in pregnancy. So how does pregnancy affect rheumatoid arthritis? Well, we know it has a predilection for women. Well, I've told you that it affects women of reproductive age. And there are other ways in which it can impact. We know that people with rheumatoid arthritis have smaller family sizes, and the reasons for that are complex. There are no known direct links with fertility, but there's a number of ways in which active inflammation can potentially suppress it. Interestingly, patients who've experienced pregnancy complications in early life are at increased risk of developing rheumatoid arthritis in later life. We don't understand the relationship between that. In previous years, it was thought that rheumatoid arthritis just got better in pregnancy. There was some mysterious factor that no one's ever identified, and we didn't need to worry about it, but that's not the case. I'll explain why in more detail. And we now know that increased disease activity in inflammatory rheumatic disease, particularly rheumatoid arthritis in pregnancy, is associated with an increased risk of adverse pregnancy complications. But of course, treatment of disease in pregnancy carries its own risks and concerns. So when we're thinking about rheumatoid arthritis and pregnancy, it's important to put it in the context of general health conditions and chronic health conditions, how they impact upon pregnancy. And there's a surveillance system in the UK called Embrace for short, measuring risk through audit and confidential inquiries of outcomes in mothers and babies. And they produce data on an annual basis. And this is now an older schematic from a few years ago. And in fact, the figure highlighting the number of women that die during pregnancy or up to 6 weeks after giving birth has unfortunately now risen to a little over 10. But what this does highlight is that 2/3 of the women who died had pre-existing physical or mental health problems. Now, thankfully, rheumatic disease is very low down on that list, but this schematic highlights the importance of thinking about things in advance, planning pregnancy or avoidance, so discussing contraception in our patients who are on medications, particularly those harmful in pregnancy, not stopping medications without thinking about the impact, the adverse impact that may have upon disease activity and pregnancy outcomes, and thinking about special considerations around birth and the postpartum period where further changes to medication may need to be made. So it's not only the doctors and the healthcare professionals who are worried about arthritis and pregnancy, it's of course the people who have these conditions. And public engagement exercises that we've done in the past have shown that people are very worried about how pregnancy will affect their arthritis, how the arthritis will affect their pregnancy, and also about drugs. But interestingly, from a more recent national survey of 178 people with rheumatoid arthritis who were considering or been pregnant within the last 5 years, the majority of people are more worried about the effect of their arthritis on pregnancy than they are about taking medications in general or even biologic medications. But as you can see, there's still a degree of uncertainty. What about healthcare professionals? Well, there's still a problem of uncertainty here, and that's a term that we use for that is called clinical equipoise, which is used to refer to a situation where there's genuine uncertainty in the expert medical community over whether a treatment will be beneficial. And I think that can definitely be applied to the use of biologic drugs in pregnancy. But why should we be worrying? Because the myth is that rheumatoid arthritis always gets better in pregnancy. 80 to 90% are figures you might find quoted in some texts and older studies. But the answer is that's just not true, because these are historical figures from retrospective studies. It's been done by looking back, where you have to recall what happened and your recall might be poor, without objective measures of disease activity or improvement. So they're all prone to bias and confounding. And recent studies, which when we looked and did a systematic analysis, which is a way of trying to gather all evidence on the subject, so to consider positive and negative findings to see what the overall outcome is, we found, looking at studies using objective measures and going forwards in time, so prospective rather than looking back, retrospective studies, we have found, I mean, most people do get better, but it's 60%. So it's not the 90% that's talked about in publications. And around half, 50% of patients are still at risk of flaring after the birth of the baby. So this is a time of great deal of physiological change in the body and also in terms of disease activity. So a lot of thought, ideally, needs to go into pregnancy planning, and that's shown in this schematic that I produced with colleagues a few years ago around managing patients with various different rheumatic diseases, not just rheumatoid arthritis in pregnancy. There's the loop of preconception planning, antenatal care, and then postpartum review on a shared decision-making basis. You can see that considerations of the disease and managing the disease are important, with looking at how medications might need to be changed. We risk stratify the condition, and this schematic applies to conditions outside of rheumatoid arthritis because there are changes in the immune system, which thankfully are less likely to occur in patients with rheumatoid arthritis that can have an adverse impact on pregnancy outcomes. And there are general impacts, general factors we need to consider, like smoking and alcohol use, to be avoided in pregnancy, and folic acid supplementation. So the general measures that all patients with pregnancy should be having in the general population. And we use these measures to then risk stratify the pregnancy. Patients who are in remission, which you remember is no disease activity, or those with low disease activity, we would classify as low risk. If they have an early stage unstable disease, it's active or flaring or high activity, then we consider that medium risk. And the high risk patients are those who have active disease, but it's active beyond just their joints. So it's affecting other parts of the body as well, with abnormalities on a variety of different blood tests and potentially damage to other organs. Thankfully, less relevant to rheumatoid arthritis, but certainly a problem in other rheumatic diseases we deal with in pregnancy. So having made that stratification, we'll then tell the patients who we've classified as low risk, they're safe to conceive. The patients with medium risk, which you remember is a degree of disease activity, will encourage contraception and disease control before considering pregnancy at a later time point. And for those with the high risk, active, multi-system disease, we'll counsel against the risks or counsel for the risks, high risks that are associated with getting pregnant at that point in time, and not avoid pregnancy at full stop, but avoid pregnancy in the first instance. There are very, very few instances, thankfully, where we'd say you must never, ever get pregnant. Pregnancy complications are increased in patients with rheumatoid arthritis, and I've given some figures in this slide of pregnancy complications like high blood pressure, reduced birth weight, a small growth status, and premature delivery before 36 weeks of pregnancy. Some of these figures overlap with the general population, but there are studies that have shown an association with rheumatoid arthritis and adverse pregnancy complications. And that association is stronger when patients have active rheumatoid arthritis. And I'll show you a couple of examples from studies that I've highlighted in this slide. And I could have selected many more, but I just couldn't summarize them in a meaningful way. You can see these are two large studies produced in recent years of hundreds or even thousands of patients with rheumatoid arthritis against controls. And they've shown an association with adverse pregnancy complications. In this term, it was preterm birth and small for gestational age, with rheumatoid arthritis in general compared with population pregnancies, but all particularly so with those with active disease. And if you remember the DAS28, the higher the number, the higher the level of disease activity. So high DAS28, increased risk of adverse outcome, low DAS28, reduced risk or lower risk. So we factor all of these things into our conversations around how to manage pregnancy. We aim to achieve disease remission for a period of time. Generally, 3 months is okay for patients with rheumatoid arthritis. We think about stopping medications that are harmful in pregnancy, but then we like to substitute them with medications we know to be safe in pregnancy to maintain disease control. And that's the key essence of how we manage the patients during pregnancy. We want to keep their disease under control, and we will then see them in the postpartum period because we've told you already, that's an increased risk for disease flare. So which drugs can be used to treat rheumatoid arthritis in pregnancy? Well, the conventional disease-modifying anti-rheumatic drugs are listed here and here. And methotrexate and leflunomide should be stopped. Thankfully, we do have drugs that are safe in pregnancy, and they're listed here. Steroids are generally safe in pregnancy, although we try to minimize the dose and the duration. But biologic drugs are put a question mark only because that terminology encompasses a wide group of drugs. And I'm going to talk a little bit more about that shortly. So how do we improve disease activity in pregnancy? Well, this schematic highlights different colored bars between two groups of patients in panel A and panel B, okay? And at a glance, you can see a clear difference is there's lots more green and yellow bars in the panel B, which implies, compared to this one, so means more patients in this cohort were in no/low disease activity with this cohort. They're both patients with rheumatoid arthritis followed through pregnancy. The difference being this is a historic cohort that began collection from roughly 2000 to 2010, and this cohort has happened much more recently. And the key difference is that in the first cohort, no biologic drugs were used in pregnancy. In the second cohort, around 50% of the patients received a biologic drug at some stage in pregnancy. So we can see improved outcomes are associated with increased use of biologic drugs in pregnancy. So I've mentioned this terminology a lot, but not actually told you how they actually work. Well, so that's shown in this schematic, identifying the different sort of alterations in the immune pathway that happen in rheumatoid arthritis and lead to an overactivation of different inflammatory factors. And broadly speaking, you can classify biologic drugs as those that inhibit the TNF molecule I mentioned earlier, so TNF inhibitors for short, and there are 5 drugs that are available on the market to block that molecule. And then versus with drugs that don't target TNF, so are grouped together under the terminology non-TNF inhibitors. And these block different components of the immune system that are listed here. But broadly speaking, just remember TNF inhibitors and non-TNF inhibitors. And the reason they're grouped together in that way is because we have a lot more experience of these drugs in pregnancy and a large number of drugs in this group, which compares with the number of drugs in this group where we have a lot less experience in pregnancy, because mainly through a chronology of time, these drugs were introduced much earlier than these drugs were. So how they act is important, but what they look like in terms of their structure is equally important. And that's demonstrated in this slide. And you can see many of the drugs are what are called monoclonal antibodies. That means they have an antibody structure that looks like this Y-shaped structure. We all have antibodies circulating around our bodies. They're part of the normal immune system that helps to target foreign invaders like coughs, colds, and germs, okay? So the foreign stuff binds to the tip of the Y prongs that vary between the molecules. So you can identify an astonishing number of different foreign particles, antigens, infections. And then they all share this backbone scaffold structure called the FC region that is actually more similar across the molecules. And that's even molecules that bind different antigenic targets. So not all of these drugs are necessarily used to treat rheumatoid arthritis. Well, in fact, they all are apart from that one. So they bind to different antigenic targets, but they all share an FC backbone across these drugs. These drugs are not actually monoclonal antibodies. They're what are called fusion proteins. So they have a receptor that binds to an inflammatory molecule that is then taken out of circulation, so reduces inflammation in the disease. So it's not a monoclonal antibody, but it has that FC portion of the molecule. And then there are drugs that target inflammatory molecules. There's this one. That doesn't have the FC portion and is bound to a protein moiety called a pegylated molecule that is relevant because the FC portion determines how the drug gets from mother to baby, because it's the FC portion of the molecule that binds to a receptor on the maternal side of the circulation and is then transferred across the lining of the womb to get into the baby's circulation. That happens very little in the first trimester, which is the first third of pregnancy, and then accelerates through the second and third trimesters of pregnancy and reaches a peak at term. So you can see a drug that doesn't have an FC portion is much less likely to be transferred from mother to baby. And in fact, there's evidence to show that that's negligible for some of those drugs that I've shown in the previous slide. So where do we find out information about the use of biologic drugs in pregnancy? Because they're always excluded from the initial studies that are done to show us that the drugs can be used to treat certain conditions with good reason. But gradually an accumulation of evidence comes from accidental exposure, unplanned pregnancies, registry use, informed use of medications based upon structure and desire to control inflammatory disease in pregnancy with the exposure of the patient to a very relatively low level of risk. And so places you can look for information I've highlighted here, and a key one is the UK Tetralogy Information Service, which is an evidence-based safety information service giving information around medications, vaccines, and exposure to other chemical and radiation agents in pregnancy. There's The UKTIS is sort of the part of the organisation that's accessed most by healthcare professionals. BUMPS, best use of medicines in pregnancy, is a very patient-facing and friendly variation on that. They both give excellent, pragmatic, useful advice. Organisations have produced advice, and I've listed some here: the British Society of Rheumatology, the American College of Rheumatology, and EULAR. And I'm going to focus on the British Society of Rheumatology, partly because I helped produce the guidelines and because it's a UK focused guideline. So we look to answer these questions. Should drugs be stopped before people get pregnant? Can they be taken during pregnancy or breastfeeding? And what about men? Can they take the medications? We tried to answer these questions by carrying out systematic searches to identify all relevant articles, and carried out a systematic review process to process the information. So all positive, negative findings, we should be getting all of those to try and then form an overall opinion of whether something is safe or not in pregnancy, or if there's minimal information, basically making a recommendation that you can't advise because of minimal exposure. So we made some general recommendations that are listed here that kind of relate to common sense about seeing someone who knows what they're talking about. Some are specific to biologic drugs that I'll focus on in a moment, and others relate to sort of minimizing drug exposure in general, but with still a strong desire to control disease activity in pregnancy. So the comments that were specific to the biologic drugs are shown in this slide. When no pregnancy-compatible drugs are suitable, control of severe life-threatening maternal disease should take priority over concerns for potential adverse fetal outcomes. All biologic drugs may be continued through pregnancy if required to control active or severe maternal disease, and then immunization schedules should be altered depending on the usage of the drug in pregnancy. So we did consider some of the older drugs that I've just showed briefly in this slide. For hydroxychloroquine, we capped the dose, but it is safe. And methotrexate is a drug that's best avoided in pregnancy, and we recommend stopping it 1 month in advance. For the biologic drugs which block the TNF inhibitors, there are some information tables that give a wealth of information that I'll highlight here. It shows the types of different studies, so hardly any randomized controlled trials looking at drug usage in pregnancy, I'm afraid. But when you pull them all together, there is a lot of large evidence or body of use of drugs in pregnancy. It defines the number of exposures, less so telling you whether it was stopped at particular stages in pregnancy. It gives you the outcomes in terms of miscarriages and the overall number of pregnancies. And remember, there are always going to be miscarriages, even in the general population. You're looking for an increased risk in drug-exposed populations compared to general population to decide if the drug has caused a problem. We make a comment on impact upon pregnancy duration and birth weight, and also comment on the presence of malformations. And then we give the recommendations that I'll focus on in a later slide. So the key thing really is the take-home message from the summary slide, where we group the biologic drugs that block TNF together here to show that basically, yes, these drugs can be used in pregnancy and breast milk and also paternal exposure. For the non-TNF inhibitors, it's a yes, but there's a caveat that use an alternative drug if you can, one that's compatible with pregnancy. But if that drug is not available, or rather not suitable, and that's often the case in patients who are on the non-TNF biologic drugs because they've tried a variety of other medications, so the normal go-to drugs in pregnancy are no longer suitable. And remember, control of maternal disease activity is key. And there was very limited evidence on the small molecule inhibitors or JAK inhibitors that, if you remember, are not biologic drugs, so I'm not talking about those. So the recommendations we made from the guidelines around the TNF inhibitors was that basically you don't need to switch a TNF inhibitor before pregnancy to anyone, despite those differences in structure that I've mentioned. The drug called certolizumab that does lack the FC portion and has that large protein moiety has been shown to have negligible transfer from mother to baby and into breast milk. So that's a good choice in pregnancy if you're picking one from scratch. If you think stopping the drug won't cause a problem with the reactivation of disease, then you think about stopping it at a particular time in pregnancy so that the baby can be free of the drug at delivery and have a normal vaccination schedule. If, however, you're worried that you need to continue the drug to control the disease, then that's fine. You just make an alteration to the vaccine schedule. We recommend stopping around a procedure such as a planned cesarean section, that's a surgery, and breast milk exposure is fine. For the non-TNF inhibitors, we said broadly the same thing with a slight difference for rituximab in that limited evidence has not shown the drug to be teratogenic, but it is compatible with pregnancy if you've got no other alternative to treat severe maternal disease. That's basically what that slide says. For all of the other non-TNF inhibitors, and I've shown an example here, we say the same thing with the additional wording in text to say any exposure, however, during pregnancy is unlikely to be harmful. The reason we have that for all the other drugs, the non-TNF drugs, apart from rituximab, is because there is some evidence to show rituximab exposure in the mid to late stages of pregnancy could cause a reduction in blood cell counts in babies, but that's not been associated with any increased infection risk. So you can see that the use of drugs, or hopefully gathered from what I've been telling you, that as we've information has accumulated over time, we've become more confident at using these drugs in pregnancy. The biologic drugs, when they were first introduced, up and for the first 10 to 12 years, basically we avoided them. Then for a period of 5 years, perhaps we were cautiously using them in the first trimester of pregnancy. Then we started to allow their use further on into the pregnancy, but more so for the TNF inhibitors compared with the non-TNF inhibitors. And we've refined that use in the latest years. And I think we now must be reaching a period where we can abandon the equipoise and say that these drugs are compatible with certain caveats. There's still a lot of work to overcome that, because studies have shown reduced usage of biologic drugs in patients postpartum who've actually stopped them during pregnancy, so we're slow to restart them. We know there's a confidence issue. Centres who have this conversation a lot are more used to prescribing the drugs. Risk perception around the people who have the conditions and the confidence of the conversations can impact on decision making. We still have limited information on the impact of this drug exposure in pregnancy and long-term development of the children, and vaccine use is another issue that I've not really touched on much today. But hopefully you can see that the safety data is accumulating, and I've shown you that increased disease activity is associated with adverse outcomes. And what this slide shows is that the increased risk of disease flare is also associated with stopping the biologic drug at the positive pregnancy test. So stopping the drug that's controlling disease activity has a harmful effect on pregnancy outcomes if it allows a reactivation of the disease activity. Another recent study has shown that the use of TNF inhibitor biologic drugs in pregnancy is associated with a reduced risk of low birth weight outcomes in patients treated with that drug. And low birth weight is a risk factor for future health problems. So in the future, I think we're going to be perhaps less stratifying pregnancy and moving towards a general consideration to use of all biologic drugs, with more reassurance around the TNF inhibitors and perhaps more of a risk assessment strategy for the non-TNF inhibitors, and then adjustment of the infant vaccine schedule according to whether that drug is given later on in pregnancy. But what would be really good is if we could predict who will flare on stopping the biologic drugs, because then that'll get around this problem of should we stop or continue. Do we have a good predictor? No, we don't. We rely upon the history, the pattern of disease control, the number of medications used, and routine laboratory tests. The ultrasound can tell us who's in remission or disease activity, but doesn't predict who's going to flare necessarily. And so there are standard tests, but no predictive laboratory tests. So knowledge of what happens to the immune system in pregnancy has been gathered from a number of different sources, and lots of different factors are being proposed as being important in producing the impact of pregnancy on rheumatoid arthritis. And T cells that I mentioned earlier and showed you in schematics have been important, particularly cells called T regulatory cells that are actually anti-inflammatory and suppressive. So when their activity is reduced, patients, that's associated with rheumatoid arthritis and increased disease activity. Reduced activity of Tregs is also associated with adverse pregnancy outcomes. So we've carried out a study at UCL done by Dr. Charles Rain to look at the use of ultrasound in pregnancy, patients with rheumatoid arthritis, and alterations in their immune system. And we've compared it with patients with rheumatoid arthritis who are not pregnant, and also population controls. And just to share briefly with you some of the outcomes, what we found was that in the patients with rheumatoid arthritis who are not pregnant, the ability of the DAS28 score to sort of predict findings from the ultrasound score are not very good, as in there's little agreement. So this line is collapsed towards the red line of equivalence. But that changes in pregnancy. You can see here in the second trimester and the third trimester and postpartum, where the shape of the curve looks different. It's more of a right angled triangle, showing that the disease activity score that I've shown you here doesn't work very well outside of pregnancy to correlate with ultrasound findings. And that's the standard finding in non-pregnancy and rheumatoid arthritis, actually works better in pregnancy. This was a surprising finding and not what we were expecting from a hypothesis, but interesting nonetheless. And when we studied some potential changes in immunologic factors, we found that some that were associated with a disease flare postpartum had actually begun to change in the later stages of pregnancy. And these are factors that are influenced in altered activation and function of regulatory T cells. So that's something we're going to be studying in more detail in the future to see if we can identify a predictive test. So the unanswered questions, I've sort of turned the title of my lecture on its head and said, rather than saying, are these drugs safe to continue in pregnancy, I would actually pose the question, is it safe to stop them in pregnancy? Because you run the risk of disease flare and adverse outcomes. Can we use alterations in those regulatory T cells that I mentioned? We don't know. Hopefully future research will help to answer that. And long-term effects of biologic drugs or even active disease or other drugs need to be carried out to better answer that question. So in conclusion, I hope I've shown you the importance of encouraging pregnancy planning and thinking of things in advance so that we can maintain disease control in pregnancy. I've reassured you that biologic drugs may be used throughout pregnancy. So in answer to the question, are they safe? It's a yes, but there are caveats, and explaining risks versus benefits empowers people to make informed decisions. So shared decision making is very important. Thank you very much.
Perfect. Thank you so much, Ian. I'm just a voice right now. I think my camera will be showing shortly, but in the meantime, we do have a lot of questions for you. So this is fantastic. First of all, there are quite a lot of questions about your role as a rheumatologist, especially things like how did you become both a researcher and a doctor, and how your work-life balance is. So do you mind just touching a little bit on that now?
Wow, that's kind of wanting a life story type answer. So I guess interest in medicine came at a very early stage, from desires to wanting to help people, but help conquer health problems. It was then through my sort of passage through medical school that I decided I definitely wanted to be a medical doctor rather than a surgical doctor, and equally then a hospital doctor as opposed to a family doctor. Those are quite broad decision trees that I think people generally find easier to make. And then once I decided I wanted to be a medical doctor working in the hospital, I was attracted to rheumatology because it's a fantastic speciality dealing with a wide variety of conditions that are triggered by overactivity of the immune system. So rheumatology and rheumatic diseases really do affect people from the cradle to the grave. So pediatric rheumatology is a subspecialty, adolescent rheumatology is a subspecialty, and as you can see from this talk, obstetric rheumatology is now a growing subspecialty. And because of the interactions with autoimmune diseases, rheumatology lends itself very well to academic practice. There are lots of sort of unanswered questions that we need to try and study through research, answer through research studies. So it's all those sort of some factors, chance elements, twists and turns in the road that sort of led me to where I am today. And work-life balance, it's good for rheumatology. So that was another part of the decision-making process.
Fantastic. Thank you so much for that. All right, so we'll move on to a bit more of a specific question about the presentation. So we have a question here. Would medium and low risks be advised to continue contraception until the risks decrease? And are there scenarios in which this will never happen and they would be suggested to not try to conceive?
So the point I was trying to make about the risk stratification, which also has to be borne in mind with the person's sort of desire to conceive, as rheumatologists, I think even I, who have an interest in this subject, are often guilty of perhaps not bringing up this subject often enough. which is usually welcomed from the person on the other side of the conversation, but sometimes isn't, because it might be, well, I don't want to get pregnant, why are you asking me? Then you just explain that it's important because if they're taking a drug that can be harmful in pregnancy, that you need to, as you know, as a medical professional, it's your responsibility to make sure that they're aware of that and that they're using appropriate contraception so that they're not going to be exposed to risks of an unplanned pregnancy with a medication that's not suitable. For the risk stratification are in the people who do want to get pregnant. We ideally like to have conversations in advance. Surprises often happen, and that's life, so we deal with it when it comes. But ideally, we like to have the pre-pregnancy planning conversation to highlight the importance of having full disease suppression on medications that are safe to continue in pregnancy. Because if they're on a harmful drug like methotrexate, you have to swap it in advance, but you don't just stop it and hope for the best. You want to switch it to an alternative medication that will maintain disease activity. So if the disease is grumbling or active, or the medication needs to be changed, you might advise just to defer pregnancy for a little while. And that's when you'd want to make sure they're still taking contraception. For the patients who have the high disease activity, and we were recommending avoid, it's usually delay pregnancy, certainly for pretty much all forms of inflammatory arthritis. So that includes rheumatoid arthritis. There isn't really an instance I can think of when I've ever had to say to someone in that situation that they should never, ever get pregnant. There is one complication that thankfully doesn't occur in rheumatoid arthritis, but can occur in other conditions, other autoimmune rheumatic diseases, called pulmonary hypertension, where the guidance used to be someone should not get pregnant with that condition. But even that is softening now, actually, because there are different degrees of pulmonary hypertension. There are ways of managing it that are safe in pregnancy. But that's the one condition where we would be very much more cautious in giving advice on someone getting pregnant. And so it would definitely be a delay for a long period of time, and there'll be lots of sort of conversations and decision-making opportunities to discuss relative risks before allowing someone to proceed. So that's where the contraception is sort of applied.
Perfect. Thank you so much. The next one here is what determines how long you have to wait until you can get pregnant after stopping methotrexate? There is some confusion about some people believe it's 6 months, but you said at least 1 month.
Yeah. So that's a good question. So in terms of sort of the simple time advice, as in how long is it safe after stopping the drug, there is a lot of conflicting information out there, unfortunately, that people can still find available. What you will find in the latest guidance from the British Society of Rheumatology that I highlighted in the talk is that it should just 1 month in advance is fine. And there is evidence that we found from our systematic review to support that. The older guidance of 3 months, 6 months, sometimes even 12 months was sort of based upon fear, really, and lack of evidence, rather than good evidence to show that it's harmful. In fact, the evidence that low-dose methotrexate is harmful is lacking. High-dose methotrexate is definitely harmful, but the doses at which it's used to abort pregnancies or used as chemotherapies, when it's 10, 100, 1,000-fold compared to what we use to treat rheumatic disease. But the other part of that, the answer to that question is you must stop the drug, but also ensure that disease control is maintained. So that's where 1 month is dependent upon maintenance of disease control.
Great, that makes sense. Thank you. So here we have a question about what happens if there are no biological drugs available for the woman during pregnancy who shows a constant flux with severity of symptoms?
So that's a tough question, and I guess it depends what they mean by no biologic drugs available. Hopefully, if in the UK, the NHS, things may be bad, but they're not that bad. Biologic drugs are available. It's more a question of suitability. So if sometimes you can get to this situation where someone has tried they've gone through the different phases of that schematic that I showed you, where the conventional drugs don't control the disease. You then enter phase 2 and sometimes even phase 3, which means cycling around different biologic drugs. And there are restrictions on our prescribing of biologic drugs. So we might find ourselves in the situation whereby someone has sort of used up their allocation of biologic drugs, and so we can't easily switch them to another. In that circumstance, we'd think very carefully about, is the drug actually controlling the disease to some degree that's not being appreciated? Can we add in anything else to try and improve disease control? The pregnancy-compatible medications like sulfasalazine, hydroxychloroquine, corticosteroids. Is there some other way that we can try and maintain disease control? And then maybe accepting a low level of disease or a degree of disease activity, because people do still flare in pregnancy and we do still manage it in the best way that we can. And of course, people with rheumatic disease have often thought very long and hard and planned pregnancies in advance. So it's very strongly desired. So we do try and work with people in that way to make it possible.
Great. Here we have a question about, sorry, I don't know how to pronounce this word, clinical equipoise.
Clinical equipoise, yes.
Have you experienced that as a rheumatologist and a researcher?
Yes, so very much so in terms of the conversations. For various reasons, I've had lots of conversations with rheumatologists and obstetric medicine doctors up and down the UK around use of biologic drugs in pregnancy, and even the people who sort of use them more routinely to manage patients with rheumatic disease in pregnancy. I think there's sometimes a difference in opinion in how comfortable people are and or will allow them in pregnancy, or where some say yes, absolutely fine to continue throughout. Others say no, I'd like to think about stopping them at different stages of pregnancy. And that's reflected in guidelines that have been produced by different international organizations from all around the world as well. Some of them say yes, carry on the drug. Some say stop at a specific time. There's even alteration in the vaccine guidance as well. So it is tricky. It's tricky for specialists to come to an agreement. It's tricky for organizations that are reviewing the best evidence to come to an agreement. So it's definitely out there. The equipoise exists, but hopefully we're moving to the situation where we can be more clear in our guidance and say that the drugs are safe with certain caveats.
Perfect. Here we have a question about biologics. So if a pregnant patient chooses to stop biologics during pregnancy and sees a decrease in her symptoms, when would you recommend for her to restart the drugs to avoid a disease flare after the birth?
Yeah, so that's a great question. That's a conversation having quite a lot in the clinic. And we certainly do consider stopping the drugs at particular time points in pregnancy so that the baby can have a normal vaccination schedule. So that the advice basically is to avoid live vaccines if the baby was exposed within the first 6 months of life, if the baby was exposed to a biologic drug in the later stages of pregnancy. So that when do we restart? So basically, I would advise sort of restarting sooner rather than later. So if the person has stopped a biologic drug at the appropriate time point in pregnancy, so the baby is deemed to be drug-free at birth, okay, you can restart the biologic drug whenever you like, and I would advise as soon as possible because it does not transfer from mother to baby via breast milk. So basically within a couple of weeks of birth, unless the mother had a surgical procedure or some complication that might mean there's a clinical reason to sort of defer starting the biologic drug a little bit later. Can I just ask, I forgot to put my acknowledgement slide up. Would it be possible to just put my last slide up on the screen whilst we're going through the questions? I forgot a very important slide at the very end of my talk. I don't know if that's possible or whether I can do that by sharing my screen. Perhaps might be what's possible.
We can see the presentation now, yeah. So.
Great, okay, and then I'll just quickly jump to the end. Sorry, please carry on asking the questions. I just realized I'd forgotten a key slide that I'm going to show there.
No worries at all. And just to clarify on the last question, this is a personal question for me. So, would that mean that you want to restart the drugs even before there's a flare up in the symptoms?
Yes, basically, because I've told you that although the majority of patients with rheumatoid arthritis do get better in pregnancy, remember the figures from the studies before increasing use of biologic drugs was 60% improvement, there was still a risk of 50% flare. And as I mentioned, we have no good predictors other than we know that stopping biologic drugs is a predictor of flare. So why wait for the flare? The person needed the drug before they got pregnant. So even though the magic pregnancy factor that we've yet to identify has done something to improve their condition, that is removed once the placenta is delivered and the baby's delivered. So the likelihood is their disease will flare. So why wait for that, particularly when you're nursing, looking after a newborn baby?
Perfect, thank you. We have more of a general question here. So are defects in T regulatory cells the main cause of autoimmune issues?
So that's another very good question. It's certainly a cause that we have studied and focused on. If you remember, I showed a slide that showed various different factors which have been identified. So I wouldn't want to claim that the defects in regulatory T cells are the only factor, but I think based upon the sort of body of evidence that's been produced to date, both in patients who are pregnant and not pregnant with rheumatoid arthritis, that they're certainly an important factor. So I think definitely worthy of future study, but I wouldn't like to claim they're the only factor.
Perfect. And then a little bit outside of the topic of more about your research, what is something you wished you knew before entering the world of research?
Wow. What did I wish I knew? Well, it's always easy to think of things that you wish you knew in retrospect. I can think of many ways in which I've applied that to my work and personal life. I'm trying to think of one that might be specific to a research factor. I guess, had I known how frustrating certain things could be, it might have made me think differently, but equally then I'm also aware how rewarding things can be. So, the old adage that good things come to those who wait or strive hard, I think is very true in the research setting. That there are lots of things I wish I knew now, to be honest, in the research setting that we're still trying to answer. So I'm kind of perhaps more interested in looking forwards than looking back. Although learning from mistakes, and I've made loads, promise you, is equally very important. So I guess there are things that I would do differently if I knew now, if I knew then what I knew now. There are ways in which that can be applied for sure, and that's relevant to design of research studies, appropriate controls, measurement of certain factors. So yes, I would just answer in perhaps a more general way to that question, which is very, very tough questions, this. Yeah.
Well, very nicely answered. And just jumping off from that, how does UCL prepare their medical cohort for the world of research, in your opinion?
Yes, good question. I can see there's lots of prospective audience out there. In fact, well, Nora is probably a good person who could perhaps share the answer to that question as well. So from my perspective, I would answer that students are certainly given to exposure because many of the clinical environments that they work in are research active environments. So I think there's exposure both when they're working at the bedside, they're working with clinicians who are very used to thinking from the bench to the bedside and even back again to help inform decision making. They'll be dealing with patients who are participating in clinical research in various ways. The intercalated BSc is a year that takes you out from the medical research studies, both the classroom and the ward, to sort of be more focused on research projects, and there's many different projects available that people can choose from. So I think it's it's a research intensive environment that the university sits in, so the students are inevitably exposed to that. What would you say, Nora?
No, yeah, I completely agree. I think the UCL has an environment that sort of fosters research. You're surrounded by researchers, so sort of motivates you as a student to pursue those opportunities. I think the more motivated you are to pursue those opportunities, the more research you will do. And UCL has so many of those opportunities. So yeah, I completely agree with you.
Great.
Perfect.
Good. I'm glad we're in agreement.
Yeah. Fantastic. So we'll move to a bit more of a specific question to your presentation. We have only 5 minutes left, so I'll make sure they're not too long. So we have a nervous clinician here who is unsure. I think I remember seeing it here somewhere. Yes, there's a nervous rheumatologist who firmly believes that only certolizumab can be used in pregnancy. Is there any way you can sort of counsel around that? Or...
Well, wow, if you're not being convinced by the evidence so far. So what I would say is don't listen to me. Look at the guidance produced from all the different organizations. So the British Society of Rheumatology, I've told you I was involved with it, so that's my disclaimer. But I was one. Actually, I've listed the names of all the people that I'm showing on this slide, and this was a wide group of people. Rheumatologists of all different grades, senior, junior, clinical nurse specialists, experts by experience, patients, people who lived experience with the condition, pharmacists, obstetricians, obstetric physicians, and we had the head of the UK Tetralogy Information Service, the medical director, who basically was signing off on all of our recommendations. And if you remember, that includes that single generic recommendation that says all biologic drugs may be used to treat rheumatic disease in pregnancy. That kind of comes with the caveat around if no other pregnancy compatible drugs are suitable and certain level of disease activity. But remember, it's not just the British Society of Rheumatology, it's the American College of Rheumatology, the EULAR, the European Association, the Austrian Rheumatology Society, the Australian Rheumatology Society. Discussions on equipoise for an article that we're hoping will be published in Lancet Rheumatology next year. I've shown the list of authors here who I'm indebted to forming some of the opinions I'm expressing here, come from 4 continents. So not just the UK, but across different regions of Europe, but the USA, India, so Asia and Australia. So it's not just my opinion, it's a group of people who've really sieved, distilled the evidence. And remember, those organizations have reviewed the same body of evidence and I know I've said there are differences, but they're broadly similar. They're not yes, no around using the drugs, biologic drugs in pregnancy. They're sort of, it's more around using them at specific times, maybe, and stopping at certain time points with consideration of disease activity. So I would hope, don't just take my word for it. Read of the variety of recommendations from all those different organizations that should allow you to have the confidence to use a variety of other biologic drugs and not just the certolizumab pegol, which is a good choice in pregnancy, but it's not the only choice.
Well, I have to say that's very convincing. Just to finish off today, just one quick question. Any new biologic drugs in research at the moment?
So I guess there are always sort of new drugs in development, and that's true for biologic drugs. Whether they're going to fall into quick use in the management of patients with rheumatic disease in pregnancy is a whole other question, because as you've sort of gathered, we have a slow accumulation of evidence because patients are generally being excluded from early studies with good reason, but there is going to be a change in that, and I think there will be consideration for inclusion of patients with certain safety level set. That might mean we'll be able to talk about use of more biologic drugs in pregnancy. And the guidelines that I've mentioned do cover more biologic drugs to treat other conditions and not just rheumatoid arthritis. So yes, I think things are growing, but it's slow accumulation of experience.
Fantastic. Well, I think we'll call it a day. Thank you so much again, Professor Giles. We're out of time, so we'll have to leave it there. However, if you could please provide us with your feedback about today's session by filling out our survey. It should be now in your, it should, I don't know if it's sent via an email or if it's going to be on the chat, but just look out for the survey. Thank you all for your comments. Yeah, so the survey will be sent out via email, so please just look out for that and fill that out. That's really useful for us. Thank you all for your comments and questions. I know I didn't get through to all of them, but thank you so much. They were really great questions. And again, thank you so much again to Professor Ian Giles for a fantastic lecture. Have a great evening, everyone. Thank you very much.
Thank you, Nora. Thanks, everyone.
Thank
Bye.
you. Thank you.